Hello, everybody. It's either good morning, good afternoon, or good evening, depending on where you are connecting from. It is again a pleasure for me to chair this meeting, the second part of the meeting, of Pre-Bárány meeting, on the classification of vestibular disorders, where you will have the privilege and the opportunity to listen to the lead authors of the selection of 3 of our definitions recently published in the context of this classification. You will have the opportunity to ask questions via the chat function. The presentations themselves are pre-recorded and will be available offline from next week onwards if you enter into the private area of the Bárány Society Congress website. So we have 3 topics. One is superior canal dehiscence syndrome, Presbyvestibulopathy, and motion sickness. And so we're going to start straight away with the superior canal dehiscence syndrome, which is, I think, was an important piece of work to be done, because it has a large variety of presenting symptoms. Imaging is not always that specific, and it's important to have a good definition before you engage into possibly invasive treatments. So we have 2 presenters who come from the same hospital and who have made most of the work which is now going to be presented. One is John Carey, who is the professor of otolaryngology, head and neck surgery at Johns Hopkins University School of Medicine, and he is the director of the Division of Otology, Neuro-Otology, and Skull-Based Surgery. He has been involved for many years in many projects refining the diagnosis and management of superior canal dehiscence syndrome over the last 20 years, and has published numerous manuscripts and chapters on this topic. And his co-presenter is Brian Ward. He's assistant professor in the same unit, and he has also been involved in the same research projects. And we are very curious on your presentation. So please, we are listening to your presentation now.
Hello, friends. I'm John Carey from Johns Hopkins University.
And I'm Brian Ward, also from Johns Hopkins University. And we're going to be discussing today the diagnostic criteria for superior semicircular canal dehiscence as developed by the International Classification of Vestibular Disorders. So these are the diagnostic criteria that were recently published. And in summary, there are 3 major categories. One is symptoms that are consistent with a third mobile window into the inner ear. The second is at least one diagnostic test indicating that there is pressure being transmitted through a third mobile window. And the third is a high-resolution temporal bone CT with multiplanar reconstruction demonstrating a dehiscence of the superior semicircular canal. The 4th major category is common to many of the ICVD diagnostic categories, and this is not better accounted for by another vestibular disease or disorder. So how did we get here? This is the earliest demonstration I could find on the investigations into a third mobile window. This is from the Hungarian otologist Adam Politzer, and he performed early experiments in which he made a fenestration in the superior semicircular canal and inserted a manometer that he glued in place. And what he found is if he applied pressure either to the eustachian tube or to the ear canal, he could record this as a pressure being transmitted directly to the inner ear after an opening had been made. Pietro Tullio, famous Italian, administered tones to the fenestrated labyrinth, so shown here in a rabbit sample, and as well as a pigeon. So in this experiment, what he's doing is he's delivering a tone, shown by the square wave, and recording head nystagmus in a pigeon that had a fenestrated semicircular canal. And you can see that as the tone is being administered, the pigeon has nystagmus and presumably vertigo. This today is called the Tullio phenomenon, and we still use it to describe symptoms related to superior semicircular canal dehiscence. Some early temporal bone histopathology also identified defects in the bony labyrinth. In this example here from Felix Nager from 1947, you can see an opening of the bone over the superior semicircular canal. Nager called this senile osteoporosis of the petrous bone. At that point, they had not made correlations, as far as we could tell, with patient symptoms, but described it anatomically. The next major advance in understanding of the physiology of superior canal dehiscence syndrome came from Julius Lempert, who popularized canal fenestration procedures in the 1940s and 50s. Lempert was a surgeon in New York City who was treating a disorder called otosclerosis, in which patients develop a fixation of the stapes bone. Once that occurs, patients lose hearing because they don't have the compression and rarefaction of fluid through the cochlea. They have a single window, the round window. And so Lempert developed this procedure in which he would make an opening, or called a fenestration, in the lateral semicircular canal shown here. So here's the incus and the malleus, and the ear canal is here. And then this is where the lateral semicircular canal was. So what this does, as shown in this picture from Terence Cawthorne, is it develops two windows that are now functional. So if you imagine that the stapes and the oval window is not functional, the round window and this new fenestration can transmit pressure through the inner ear and restore some hearing. And this was a very successful surgery for otosclerosis before stapes surgery became further developed. John Lindsay and Cawthorne both had patients in whom there was a fenestration made, but the stapes remained mobile. So in those cases, the patients developed new symptoms. When patients heard loud sounds or they put pressure in their ear canal, they would get vertigo symptoms. And you can see this because if you get a pressure now wave through the stapes, instead of it being decompressed at the round window, part of that pressure is going to be transmitted up through the new fenestration. And both of them in papers called this a third mobile window, which we still use the terminology today. Lloyd Minor at Johns Hopkins saw a patient who experienced dizziness in response to loud sounds. And he was prepared to put all this together because he knew of the physiology described so well by Florence and Tullio. He also had the ability to record three-dimensional eye movements. And what Minor did is he worked with one of the radiologists, Weg, and they created a multiplanar reconstruction in the plane of the superior canal and demonstrated a dehiscence, or an opening. So there should be bone covering the superior canal here, but it is dehiscent. And he described 8 patients who had sound or pressure-induced dizziness, or nystagmus, in the plane of the superior semicircular canal. We later learned more about the auditory symptoms associated with superior canal dehiscence syndrome that are often even more bothersome to patients. The ICVD committee considered both auditory and vestibular manifestations of SCDS, and we're going to be describing some more of this physiology later in the talk. The consensus emerged after a number of group discussions. The committee was established to represent surgeons and neurologists from around the world who had scientific and clinical expertise in superior canal dehiscence syndrome. And the initial criteria was proposed in February of 2017, presented before the Bárány Society in March of 2017 for tentative approval. And then we continued to meet and revise the criteria, eventually editing over 25 versions of the final, until the final document was published this year in the Journal of Vestibular Research. So Dr. Carey and I are going to go through each of these major criteria, and I'll begin by discussing the first, which is symptoms, the reasons that patients end up coming to your clinic with for this diagnosis. The symptoms that we decided to include as part of the criteria are all those that are consistent with a third window lesion. So the first is bone conduction hyperacusis, which is a sensitivity to bone conducted sounds, sound-induced vertigo or oscillopsia time-locked to the stimulus. We'll talk more about that. Pressure-induced vertigo or oscillopsia time-locked to the stimulus, as well as pulsatile tinnitus, which is the sensation of hearing your heartbeat in your ear. So the auditory symptoms of SCDS that were included are those such as bone conduction hyperacusis. So that is when one hears one's voice loud or distorted in the ear, called autophony. an abnormal perception of one's own internal body sounds, things like hearing loudly one's eyeball movements, blinking, crepitus of jaw or neck movements, or footfalls. Sound-induced vertigo and/or oscillopsia, the Tullio phenomenon, also occurs and should be triggered regularly by stimuli that are characteristic to the person and to the ear in question. The vestibular symptoms are triggered during exposure to sounds, most commonly. Provoking sounds tend to be loud or low frequency, and the pressure or sound stimulus should be time-locked to the sensation, which implies that the onset and duration of symptoms are linked. We included symptoms that are most directly attributable to the physiology of having a third window. So the next slides are going to just discuss a little bit more about what is a third mobile window. So you got a little bit through the history already. This is the stapes and the round window, and here's where the dehiscence in the superior canal is going to be. These cartoon images are thanks to Michael Teshida. So in this illustration from Dr. Teshida, you can see that sound enters the stapes footplate through vibrations of the eardrum and the ossicles, and it's decompressed at the round window. And this is the normal, this creates the normal sensation of hearing. In the condition of an opening in the superior semicircular canal, now there's a new pathway for sound or pressure to be delivered across the sensory epithelia of the labyrinth. That can create dizziness in response to sound or pressure changes. And it also provides a new low impedance pathway for bone-conducted sounds to enter the inner ear and stimulate the cochlea. And this allows us to hear superhuman noises such as their eyeballs movements, footfalls, neck creaking, etc. We're also going to be discussing some of the controversies that came up during the committee meetings. One is related to different kinds of symptoms associated with SCDS. There is a broad variety of symptoms that patients can present with. Some will have more auditory symptoms, some having more vestibular symptoms. And to accommodate for this variability in presentation, we propose that patients are required to have at least one symptom in the category of symptoms related to a third mobile window. And this would allow people to present either with auditory or vestibular complaints or both. We specified that vertigo symptoms should be time-locked to the stimulus. So it's unknown if there might be a brief after effect following the stimulus. Nevertheless, the idea was that it should be closely aligned as to discriminate it from vestibular migraine, in which patients may hear a loud sound and experience dizziness that then persists long after the stimulus stops. There are a number of other symptoms that patients present with, including chronic ones such as chronic disequilibrium, headaches, and brain fog that overlap with other vestibular syndromes. We also felt that earfulness, even though it's a common symptom, has overlapping conditions and was therefore excluded from one of the major criteria.
Thank you, Brian. So as Dr. Ward indicated, the third mobile window theme runs throughout these criteria. And the committee felt it was important that we have measurable and observable and measurable signs of a third mobile window in addition to the symptoms and the CT scan. So specifically, nystagmus that is characteristic of excitation or inhibition of the affected canal evoked by sound or changes in middle ear pressure or intracranial pressure. Those would be through the mechanisms that were just illustrated in those cartoons. A second possibility is low frequency negative bone conduction thresholds on pure tone audiometry, and we'll discuss that in more detail. And thirdly, enhanced VEMP responses, either a low cervical VEMP threshold or a high OVEMP amplitude. Next. So first of all, the cardinal diagnostic test that we'd all imagine seeing in superior canal dehiscence is the characteristic nystagmus of stimulation of the superior canal, for example, in response to loud sounds. And Brian, if you can hit next. So of course, we all know that the normal way we stimulate the right superior canal is by turning the head down and toward the right side in the plane of the right superior or anterior canal. And any stimulus that produces that kind of firing, the brain will think the canal is being excited by that head movement turning right and down. Next. And it's going to produce eye movement so that the eyes roll up and torsionally to the left. Of course, they can't keep going, so they jump back, and that's nystagmus. Next. So here's a characteristic video of nystagmus in response to sound. 500 hertz tones being played to the right ear.
To the right.
When he looks to the right,
Sound on.
it's vertical.
To the left.
When he looks to the left, it's torsional.
Straight ahead.
And ahead, it's mixed. That's probably worth playing one more time. So we purposely ask the patient to look to either side
To the right.
to make sure
Sound on.
the eyeball is always moving in the plane of the affected superior canal.
Straight
Sound is
ahead.
being presented to the right side, so it's in the plane of the right superior canal. Next. So again, the nystagmus should be characteristic of excitation, or if the stimulus is appropriate, inhibition of the affected superior canal with a mixed vertical torsional nystagmus. Next. Next on the list, we include vestibular evoked myogenic potentials. This audience is no doubt familiar, but just to review, these are electromyographic responses that can be elicited, for example, by loud clicks or tone bursts that are believed to weakly stimulate the saccule and the utricle. Superior canal dehiscence lowers the overall input impedance of the labyrinth to sound, and it enhances these responses. These are vestigial, vestibulocholic, and vestibuloocular reflexes that are being activated. Next. So here is shown from an illustration by Dr. Welgampola of typical sites for recording the cervical vemp at D and E and the ocular vemp at either A to B or B to C. And you can see the characteristic for cervical P13 N23 response and for ocular N10 P16 response. And shown in these panels A and B are enhanced responses on the cervical vemp for clicks in an affected left ear going down to 65 dB, and the O vemp being shown from the contralateral eye, because it's a cross response, for stimulation of the left ear. This O vemp is large for our lab, greater than 17 microvolts. Next. Now we've mentioned conductive hearing loss, and again, this is because this third mobile window steals some of the perilymph flow from the cochlea, causing a hearing loss for air-conducted sound. However, next, there's a hearing gain for bone-conducted sound because this third window works in reverse, sound coming in through the bone, gets into the otic capsule with an overall lowered input impedance. And so we hear bone-conducted sound, voice, pulse, eyes moving, neck creaking, jaw muscles, etc. Next. And so what we look for on the audiogram is this characteristic air-bone gap, but it's not just an air-bone gap, it's negative bone conduction. So you can see the masked bone thresholds for the right ear are above the 0 line. So better than normal bone conduction, and while the air conduction is considerably worse than normal. And this bone conduction hyperacusis is what accounts for the characteristic symptoms of autophony, pulsatile tinnitus, etc. Incidentally, one can even see a Carhart notch with superior canal dehiscence, which was once thought to be characteristic for otosclerosis, but indeed you can see a notch in the bone conduction at 1 to 3 kilohertz, even with superior canal dehiscence. What distinguishes it here is the negative bone conduction. And of course, in otosclerosis, we'll see an absence of vemp responses, stapedial reflex responses, those sound evoked responses that depend on a normally functioning ossicular chain and the absence of a third mobile window. Those will be absent in otosclerosis, and they'll be present with superior canal dehiscence. Next. Now, we considered other tests that have been described in the literature. Electrocochleography, as shown in the panel here, can show an elevated summating potential to action potential response. Here we see a wildly elevated response above 1.75, which we sometimes see in the operating room when we elevate the dura off of a dehiscence, really incredibly lowering its impedance. And we see these previously unimaginable SPAP ratios. So even prior to surgery, SPAP ratio may be elevated, probably because of a hydrops ex vacuo phenomenon with low perilymph pressure. Likewise, abnormalities in power reflectance have been described. Reports have been written about pulsatile oscillations of the eyes that are measurable, and even pulsatile movements of the tympanic membrane. Now, we considered these tests, but they aren't widely described. They're not always widely available, and they can be technique dependent. So these were not included in the current criteria, but they could be considered in future revisions. Next. So next, we talk about the CT scan, which is an essential element in making the diagnosis of superior canal dehiscence. Next. So, as in so many things in radiology, it's essential to look at orthogonal angles. One cannot simply look at an image in the plane of the canal, as is shown on the left, and conclude that there is or is not bone over it, without also looking at a right angle, looking orthogonal to that plane. Now, that can be done in a standard 90-degree view going through an oblique plane. Ideally, it can be done through radial reconstructions that will demonstrate. Now, some important points that need to be considered. Not all CT scans are the same. And in fact, a poorly done CT can make thin bone disappear and give a false positive impression of superior canal dehiscence. We list here some of the essential features of a properly done CT scan. The slice thickness, which is a function of not only the collimation of the beam, but other factors, should be ideally between 0.5 to 0.63 millimeters. Future iterations of CT technology may make that even better. The field of view should be as small as possible. That is to say that rather than mapping the entire head to the image matrix, we just map the temporal bone, usually between 10 and 18 centimeters, to the image matrix so that we have full resolution. And the image filter should be set for bone edge detection. It's very important not to take a soft tissue algorithm CT and try to re-window it to look at bone. That gives a very false impression that bone is missing. Next. Here I'm showing a multiplanar technique with radial reconstructions. This is an option now available on many of the modern software packages. So we've depicted the superior canal in the plane of the canal, and these colored planes are going to now be sequentially demonstrated, showing truly radial orthogonal views. That is, every image is orthogonal to the lumen of the canal. And this allows us to pinpoint where the dehiscence is located, where it begins, where it ends. And this is an ideal reconstruction technology for diagnosing superior canal dehiscence syndrome. Next. Now, we've mentioned some controversies, and probably one of the biggest ones is the possibility of an asymptomatic superior canal dehiscence or a false positive superior canal dehiscence. So let's talk about how multi-slice CT may overestimate not only the size of a dehiscence, but even the presence of one. So what we're depicting here is, in the CT image, of course, an in-plane view of the superior canal reconstructed. And if we consider the red square, that is an image that's reconstructed from Hounsfield unit data. So radiographic transmission data. And we're limited by the fact that the the software algorithm has to create discrete voxels, units of tissue with single grayscale values assigned to them, single Hounsfield units assigned to them. And you can see, as the small blue box indicates, if you overlap a sufficiently thick area of bone, that will be assigned a value that's close to that of bone because there's not much overlap with other tissue. But you can imagine as the bone gets very thin, that could be averaged to something more like CSF or perilymph, and thin bone could be made to disappear through what's known as volume averaging, because only one value can be assigned to that voxel. So we've found that multi-slice CT overestimates the dehiscence size and in the extreme case, overestimates the presence of a dehiscence. Next. And next. So there's really probably a spectrum of intersection between the floor of the middle cranial fossa, the dura, and the superior semicircular canal. And this set of cartoons demonstrates that spectrum. On the far left, at the top, we have near dehiscence. This would be the case where there may be thin but pliable bone remaining over the top of the superior canal, and the dura, which is depicted as that plate there, could potentially transmit some pressure at some frequencies that might, for example, lead to auditory symptoms. In the second, the SCD with perilymph motion, we have a frank dehiscence and we have dura in contact with the perilymph, such that dural movement, for example, with brain pulsation, with the cardiac cycle, will move the perilymph. And that, of course, will be transmitted all the way to the cochlea and could be heard as pulsatile tinnitus. In the third scenario, we have a bigger dehiscence that allows dura to herniate down and contact the membranous duct. So now we will have endolymph motion with every movement of the dura, and that will produce vertigo. And in the extreme case to the right, we have a very large dehiscence, typically over 5 millimeters, in which dura is herniating to the degree that it actually compresses the membranous duct and essentially performs a plugging procedure of sorts, auto-plugging we call it. And in this case, the head impulse test will show reduced function in that canal plane, but it's not a rigid plug, and so it will still transmit sound and pressure and cause many of the symptoms of superior canal dehiscence syndrome. So this is the kind of spectrum we may be working with. Next.
So I'm going to finish by just discussing a couple more of the controversies that came up during the committee. And one is the difference between what we call a definite versus a probable superior canal dehiscence. So the committee discussed proposing probable and definite categories. Arguments in favor of this approach were the broad range of auditory and vestibular symptoms that have been reported by patients in the literature, as well as the possibility for superior semicircular canal dehiscence to be confirmed during surgery, as is shown in the picture here, pointed out by the yellow arrow. We considered a separate category in which a dehiscence was confirmed at the time of surgery. However, we found that this would not be helpful for patients who have to decide whether they wish to have an intervention. And many surgeries today are performed via the transmastoid approach, during which surgeons often decide not to confirm the presence of a dehiscence. So we therefore decided against making this distinction and only have one set of criteria for definite superior canal dehiscence syndrome. There have also been reports of patients that present with symptoms and signs consistent with superior canal dehiscence syndrome, as Dr. Carey mentioned, but are found at surgery to have thin or compliant bone over the superior canal rather than a true dehiscence. While evidence supports that even pinpoint dehiscences can alter pressure transmission through the inner ear, these are not readily detectable with even the best imaging. Even more controversial was the notion that physiologic third mobile windows could occur in the absence of radiographic abnormalities of the otocapsule, and therefore the committee decided that additional data are needed before we include these in ICVD diagnostic criteria. The committee also discussed pediatric superior canal dehiscence. We ultimately decided to exclude this because we felt that a couple of reasons. One is that children might present differently than adults. Children may not realize that their symptoms are unusual. And for a diagnosis, we would hope that we would have quantifiable audiometric and vestibular testing to indicate that a third mobile window is transmitting pressure, similar to what's available for adults. VEMPs, however, have been performed in children as young as age 3, and bone conduction thresholds can be replicated in children typically around age 5. Finally, we discussed a number of SCDS-like conditions. So these are cases in which there may be a third mobile window, for instance, as has been reported for enlarged vestibular aqueducts, posterior semicircular canal dehiscence, lateral semicircular canal dehiscence, as well as others. And they may have symptoms that are similar to those who present with superior canal dehiscence syndrome. The diagnostic criteria proposed here, however, do not include third mobile windows in other semicircular canals. It's conceivable that symptoms could vary depending on which direction the sound or pressure energy is transmitted through the inner ear, and additional data are needed. And finally, perilymphatic fistula was felt to be different enough to warrant its own diagnostic criteria. So I just wanted to review one more time the published diagnostic criteria for superior canal dehiscence syndrome. You have to have one of each of the 3 major categories, which is a symptom consistent with a third mobile window, evidence on physiologic testing of the third mobile window transmitting pressure, and a high-resolution CT scan, with things not being better accounted for by another vestibular disease or disorder. The symptoms specifically were bone conduction hyperacusis, sound or pressure-induced vertigo, or pulsatile tinnitus, all of which could be localized to third mobile window physiology, and at least one physiologic measure, including nystagmus in the plane of the superior semicircular canal triggered by sound or pressure, negative bone conduction thresholds, or enhanced VEMP responses. And the committee decided that high-resolution temporal bone CT imaging was important for the diagnosis as well. So I want to thank you for your time and attention. We are here and happy to answer any questions that you might have.
Well, thank you so much, John and Brian, for this very, very nice presentation. And I think you really managed also to portray nicely how difficult it can be when you go to the cutting edge knowledge and you see the insecurities, and that for some aspects we still need to wait until more data are there. And also thank you for describing very well the controversies which were raised during the elaboration of this definition. We got in a couple of questions. I think you can see them yourself. The first one addresses to the issue of bone-conducted hyperacusis. So the question is, the mechanism is related to the sound from the stapes to the superior canal dehiscence. So why the patients with superior canal dehiscence syndrome have symptom of bone-conducted hyperacusis?
So I think I'll start with this. So I think this is by Professor Yin. Thank you for your question. You're right. So part of the mechanism is from loud, low-frequency sound or pressure applied to the stapes. And that does transmit pressure to the inner ear across the sensory epithelia of the vestibular system, causing the dizziness symptoms that people experience. But it also causes the air-conducted sound for low frequencies to part of that energy to be diverted away from the cochlea and gives you a hearing loss for air-conducted sound. And that's part of the mechanism. The other part of the mechanism, however, is that there's now a new low-impedance pathway for bone-conducted sound. So sound pressure can enter into the inner ear through the dehiscence, and this allows people to hear things like their dural pulsations, and eyeball movements, other bone-conducted sounds, etc.
Okay, thank you.
If I could follow up on that, it's often hard to get my head around this. And, I think it's important to go back to the understanding that the middle ear is really an impedance matching wonder. It takes air conducted sound and changes it to movement of fluid. So it has to match this incredible impedance difference between the air and the fluid. Now imagine if you literally stood that on its head, and what you have with a third mobile window at the floor of the middle cranial fossa is like plugging your stapes into the dura or into the bone. Now you're matching the impedance of the bone to what is normally matched to the air. And so patients describe this very disturbing sense of distortion of any sound coming from within their body. I hope that helps.
Thank you, John. The next question addresses patients who are reluctant to undergo surgery, if there is any useful drugs for them.
Well, so on behalf of the committee, we were charged with coming up with diagnostic criteria. We didn't really address the specifics of treatment. This is a mechanical problem. It's an impedance problem. And so there's very little evidence that anything will induce bone to grow in the otic capsule. One of the things we know from fundamental histopathology is that otic capsule bone is unique. It doesn't heal after it's fractured. It's probably because the stapes is the only piston joint in the body, and bone formation in the otic capsule in the evolution of bone had to be altered to preserve that. There's a disease where bone does grow, and that's called otosclerosis. So we don't think that bone growth is a realistic solution. One thing short of surgery is sometimes patients will benefit from a ventilating tube in the eardrum. And those are generally the patients who find that performing a Valsalva maneuver causes their symptoms, or manipulating pressure in the external auditory canal causes symptoms.
Okay, so we have a question, a bit longer question from Raymond van den Berg from the Netherlands. So he asks if selective hypofunction is only seen in cases of autoplugging, or does a fenestration maybe also lead to a change of the laminar flow in the canal to turbulences in the flow and less deviation of the cupula, and therefore selective semicircular canal hypofunction can also be seen in other entities within the semicircular canal dehiscence spectrum. So dura in contact with perilymph or endolymph. But that sounds like a very surgical question.
Yeah, I can start. So I don't know that we've reported this. I think that patients with autoplugging tend to have, at least on imaging, larger dehiscences. And so presumably it has to be large enough for the dura to kind of sort of hang down into the canal and kind of press and impair endolymph flow. Yeah, I'm less certain about whether there could be some change in endolymph flow with just a dehiscence, but I kind of would suspect not, but I'm not sure.
Okay. The question by David Newman-Toker. Can you speak briefly to the issue of how many clinical symptoms or signs you would want to be together, single versus multiple symptoms, in order to pursue temporal bone CT in the first place?
Yes. So the short answer from the committee is one of each. There should be at least one clinical symptom of the third mobile window and one measurable sign. Now, we knew that this could be a tricky issue for the Bárány Society because we think mostly about vestibular system and vertigo, but some of these patients can really only have auditory symptoms. So it's not unusual for a patient to say, I really don't have vertigo. I have, occasionally some imbalance. What really bothers me is my autophony or my pulsatile tinnitus. And then what we see on the audiogram is that low frequency air bone gap with negative bone conduction. So that would be enough to warrant getting a high resolution CT.
Okay. Now here's a question which is related to the diagnostic criteria as you are defined. And it is about the selective loss of gain in the semicircular superior canal on head impulse test, because according to literature, wide-sized dehiscence presents with reduced VOR gain values for the affected canal, likely due to incomplete dural plug or to the dissipation of mechanical energy through the dehiscence. Since detection of isolated functional loss of a semicircular canal is highly specific for supracanal dehiscence, why not include it in the diagnostic science?
Thanks, Andrea. That's yeah. I think just carrying on from the last answer, that it may be highly specific for patients with superior canal dehiscence with a large dehiscence. We're kind of blessed in that there are a number of physiologic tests that are all highly sensitive and specific for third mobile windows, and so we considered others like electrocochleography or power reflectance, etc. It's possible that this may emerge as another criteria in the future, but we didn't include it in this one because there wasn't enough data.
Okay. Here's a question about, do you have any recommendations for women affected with superior canal dehiscence syndrome concerning labor? Is it an indication for cesarean section?
That's a great question. I can tell you I've had several patients who have delayed pregnancy or chosen even to have a cesarean section. It's really hard for me to recommend, yes, you need a cesarean section. I would say if the patient has demonstrable Valsalva-induced vertigo and nystagmus, that may be a reasonable choice. It's also been a reasonable choice for some women to choose to have repair before they get pregnant. It's a tricky issue. I don't think we know enough yet.
Okay, then we have a question by Antonio Lopez Escamez. He would like to know about the frequency of tinnitus in superior canal dehiscence syndrome. He is not asking about pulsatile tinnitus, I mean tonal persistent tinnitus, giving the strong association of tinnitus and hyperacusis. I don't know if there's an answer to that.
Yeah,
I would say it's quite variable. Some patients actually have some sensory neural hearing loss from superior canal dehiscence. I'd say that's actually quite rare. But we've always wondered if there are patients who are at risk, who have a fragile ear by virtue of having a dehiscence. So maybe having a dehiscence allows more sound energy into the ear overall over a lifetime, even though some of it is shunted away from the cochlea. Perhaps there's some frequency dependence where sound is actually amplified in the cochlea. I do know that some of our basic science colleagues have looked at this, and there are some changes in technical measures like wideband reflectance, and so I think more is to come. I think we don't really know yet the effects on sensory neural hearing very well.
Okay, there is a question: is MRI has any place in the diagnostic of diagnosis of superior canal dehiscence?
Yeah, I think we discussed this in the committee a little bit. I think we decided that MRI just probably doesn't have as much sensitivity and specificity as CT scan. It suffers from some of the same problems that a CT scan does with partial volume averaging. So canals can look dehiscent, for instance, on coronal images of heavily T2 weighted sequences. But when you get a CT scan, it may actually not be dehiscent. We do sometimes use MRI on these heavily T2 weighted sequences, your CISS or Fiesta sequences, to determine whether the canal was adequately plugged if a patient is having symptoms after having undergone a plugging procedure previously. You can see a fluid defect where the plugging material was, and you can try to figure out whether that was adequately plugged on both sides of the dehiscence. And then some people will use MRI scans to look for tumors or other encephaloceles or things that might be associated with dehiscence, but those are more exceptional.
Okay, thank you. So I think we take two more questions, then we need to move on. Is there a place for blocking the round window to control symptoms?
So again, the committee didn't address treatment per se, but I'll just say in my own experience, I don't use the round window plugging procedure. If we keep the third mobile window as our operating model, making the normal second window higher in impedance really doesn't make sense. It should shunt more energy through the dehiscence. Now, that being said, I have seen patients who've had it done and gotten relief of their symptoms. I suppose the possibility is that there's a frequency, there's a change in the frequencies that get transmitted. I sort of view, if you go back to those wonderful drawings that Brian showed from Cawthorne, this is a bit like a woodwind instrument. And depending on where you open the valve determines what frequencies get through. And so perhaps by altering the bell of the instrument, sort of putting a muffler in the trumpet, if you will, you alter the overall frequency characteristics of the system. The problem is I don't know how to predict that. And I don't know whether the frequency changes would actually benefit the patient or make things worse. But I'm open to hearing a physiologic model of how that would work.
Okay, I got the warning that we still need to move on, but maybe a last word on the common misdiagnoses and pitfalls as a last question, because I think that's an important one.
Yeah, so there's a portion of the manuscript that discusses overlapping diagnoses. We tried to limit our symptoms to diagnoses or to third mobile window physiology. So we'll exclude some of the chronic symptoms like that might be overlapping with vestibular migraine or triple PD. There are other auditory diagnoses as well, like patulous eustachian tube, for instance, that'll also present with aural fullness. And I think you have to be careful about ruling out these other diagnoses. But I think if you meet those three criteria, the major categories, you can be confident in the diagnosis of the superior canal dehiscence.
Okay, so thank you again very much, both of you, for this brilliant presentation and discussion. And we need to move on to our next presentation, which will be on Presbyvestibulopathy, given by Yuri Agrawal. Yuri Agrawal is also a professor, Division of Otology, Neurotology, and Skull-Base Surgery in Johns Hopkins University School of Medicine, and she has a long-standing interest in the aging of the human vestibular system, and to study, and has grants to study the impact of vestibular impairment and falls in risk in patients with Alzheimer's disease. And she was the head for the definition subcommittee on presbyvestibulopathy. So we can launch a presentation now, please.
Hi, my name is Yuri Agrawal. I'm a professor of otolaryngology, head and neck surgery at Johns Hopkins School of Medicine. And today I will talk about our diagnostic categorization of presbyvestibulopathy, which we developed in 2019. So the first point that I wanted to make is to bring us all to recognize that there is a changing demographic taking place globally, and that the number of older adults is projected to increase dramatically. For example, in the year 2050, there are around 2 billion older adults projected to be present in the population. This increase is largely experienced among less developed countries, also in more developed regions of the world. And so clearly a global phenomenon that we are contending with here. Some more local data to the United States, where some of the work that laid the groundwork for the presbyvestibulopathy diagnostic criteria were established amongst other regions as well. So here's looking at the National Health and Nutrition Examination Survey, which is a population-based survey of the United States, looking at the increasing prevalence of a few very common conditions in older adults, dizziness and falls. And you can see clearly that the prevalence of these conditions increases sharply with age, with nearly half the population reporting dizziness by the time they're age 80 or above, and also a significant proportion reporting experiencing a fall in the last year. So these are very common outcomes among older adults. Here's a study that was done a number of years ago by an internal medicine practice, looking to see among an internal medicine primary care practice of patients who presented with dizziness, what were the most common reasons or causes that they experienced the symptom of dizziness. And once the primary reason was subcategorized into these different groups, it turns out that vestibular etiologies were among the most prevalent at 20 to 50% of the reasons explaining individuals' dizziness. And these include very common conditions such as benign paroxysmal positional vertigo, or BPPV, and also vestibular hypofunction that occurs as a function of the aging process, which is what we'll explore and highlight in subsequent slides. Other conditions that led to the symptom of dizziness included cardiovascular conditions, systemic infections, psychiatric conditions, metabolic disturbances, and also the use of medications that had as their side effect dizziness or imbalance symptoms. Here's a study, again, using data from the National Health and Nutrition Examination Survey, which is a study of the US population, looking specifically at the prevalence of vestibular impairment in the healthy older adult population, the healthy adult population. And this is drawing from that previous slide, looking to see, what is the prevalence of a loss of vestibular function with the healthy aging process that could be contributing to the symptoms of dizziness and imbalance. And this is a particular study that used a postural metric to estimate vestibular impairment, specifically the ability to stand on a foam pad with one's eyes closed, which is really a measure of the ability to use vestibular information. And again, a striking increase in the prevalence of the inability to stand under these conditions with age, such that in individuals over the age of 80, there was nearly an 85% prevalence of this vestibular or postural impairment. Here are some studies that have looked more specifically at vestibular physiologic function. And this is drawing from different regions around the world in terms of measuring, in this particular case, semicircular canal function based on head impulse testing among a cohort of healthy adults, including adults in their at older ages, 60 and above. And essentially, it can be observed that there is a decline in vestibulo-ocular reflex response that occurs as a function of age, perhaps not a steep decline. And in this study from Matino Soler et al., there was a decline that was observed, notably at more high frequency or high acceleration head impulses that were delivered, high velocity head impulses that were delivered, that revealed that there was this decline in VOR responses or VOR gain starting around the 5th and 6th decades of life. Here's a study that was done in Baltimore, looking at a study of older adults, healthy older adults. And we found in this study that the prevalence of any impairment in the head impulse test was about 50% in this cohort of healthy older adults. So giving some sense of the extent to which these declines do in fact occur as a function of the healthy aging process. Here's another study from a group looking at cervical vestibular evoked myogenic potential, or CVEMP responses in, again, a cohort of older adults, again, showing a fairly substantial decline in cervical VEMP responses that are corrected for underlying electromyographic activity as a function of age. And here are some circles denoting individuals who have superior canal dehiscence, so a specific pathology that manifests in elevated VEMP responses. But in the otherwise healthy adult population, there is a decline in response amplitude with age. And the CVEMP, as we know is thought to be an indicator of otolith function, more specifically saccular function, particularly with the sound-evoked CVEM. And so this is perhaps capturing a decline in otolith function as a function of age. I want to move on and talk about, we sort of established that vestibular impairment as measured based on postural metric, based on physiologic testing, and based on symptomatology, for example, the presence of dizziness, is prevalent in older adults, achieving rates of 50%, 80%, of older adults, depending on the specific metric that's utilized. So a very common condition in older adults. Here's another set of studies that looked at what might be the impact of the loss of vestibular function in older adults. And here's a study that, again, was based in the United States, looking at individuals who reported dizziness or balance problems. And again, a group of healthy older adults that from a population-based survey here in the United States. And this slide is just meant to highlight that among individuals who reported dizziness, these individuals stated that dizziness is one of the most influential symptoms affecting quality of life in older individuals, with a majority of them experiencing, for example, difficulty in the ability to exercise or do activities of daily living, such as shopping or driving a motor vehicle or participating in social activities. So consequential impacts on daily life associated with balance impairment and dizziness in older adults. Here's another slide discussing resource utilization, healthcare resource utilization among individuals who report or who experience dizziness or balance problems. And you can see that 50% of them saw a healthcare professional for their problems. A number of individuals saw, so 40% saw one, a number of individuals, sort of an equal number, 50% saw multiple providers to further understand and understand the etiology of their dizziness. And this is the frequency with which different types of providers were consulted about these symptoms. Resource utilization also in terms of imaging resources that are utilized. So clearly there's an impact societally, socioeconomically, of these symptoms that are experienced in older adults. Here's a study that we did looking, again, from the National Health Nutrition Examination Survey at that postural metric, or that estimate of vestibular impairment based on that postural metric. And we did find that individuals who had impairment on this metric had a 2.5-fold increase in the risk of falling. And falls, as we know, are hugely impactful in older adults. It's been shown that 1/3 of community dwelling adults over the age of 65 fall each year. 10% of these falls result in major injuries, such as hip fractures. And having a fall and an injury associated with it confers a 10-fold increase in the risk of nursing home placement for these individuals. So significantly associated with loss of autonomy and institutionalization associated with a fall and injury related to that, with significant societal costs, with costs estimated to exceed $34 billion annually just in the United States. So falls are a huge chronic condition or chronic risk faced by older adults. More recent literature by our group and a number of other groups are increasingly documenting or suggesting a relationship between vestibular impairment in older adults and various dimensions of cognitive function as well. Here's a study that we did, again, looking at the National Health Nutrition Examination Survey and the relationship between performance on the postural metric and various cognitive outcomes, including the digit symbol substitution test, which is a test that taps into spatial cognition and attention skills. And we did find a significant relationship after adjusting for a number of confounders between vestibular impairment or balance impairment and poor performance on this particular cognitive test. Here's another study looking at a question-based assessment of vestibular impairment, a condition that has been termed vestibular vertigo, which is defined based on the presence of rotational or positional vertigo or recurrent dizziness with oscillopsia or imbalance. And again, there is a relationship, a significant relationship after adjusting for a number of confounding factors between vestibular vertigo and difficulty remembering or confusion. So again, tapping into some cognitive skills, as well as other psychiatric conditions such as depression, general anxiety, and panic disorder. So suggesting that the impact of vestibular impairment significantly affects elements of physical function in older adults, such as balance and falls, but also has this additional dimension impacting daily cognitive skills as well, and perhaps also emotional health in older adults. Here's a study that was also done from the National Health and Nutrition Examination Survey, looking at the relationship between vestibular impairment and the ability to carry out common activities of daily living. And we found in the study that, for example, some of the most common daily tasks that are required to accomplish managing money, eating effectively, getting in and out of bed, were significantly compromised by having vestibular impairment. So it affects many dimensions of daily life. And here's another study that looked at the relationship between having dizziness and balance impairment and mortality in older adults who experience these symptoms, and essentially looking at unadjusted mortality rates in adults. There's a 9% mortality rate in that given year for an adult who reported having dizziness or balance problems. And that rate is on par with other significantly morbid and mortal conditions that are known to affect older adults. So in light of that, given the growing evidence for the prevalence and impact of age-related vestibular loss, we proposed defining vestibulopathy, PVP, as has been done for the aging of other sensory systems, such as presbyopia, which is age-related loss of vision, and presbycusis, which is age-related loss of hearing function. And so similarly, we wanted to create this category of an age-related loss in vestibular function, which appears to exhibit similar patterns in terms of the prevalence and perhaps the impact as well. And so our goal in creating this diagnostic category was to create this presbyvestibulopathy diagnosis that encompassed mild or incomplete vestibular losses that are attributable to the normative aging process, consistent with other age-related sensory losses, again, such as presbycusis or presbyopia, which are similarly incomplete losses, as opposed to deafness or blindness, respectively. We felt that developing formal criteria to define presbyvestibulopathy could be useful both in the clinical setting, for example, in early identification, diagnosis of this condition, and recommendation for treatments such as vestibular therapy, where otherwise that may not be routinely done at present, and also in the research setting, for example, with respect to standardizing the characteristics of study participants across studies to allow better pooling of study data. So here are the diagnostic criteria that we developed based on the consensus process that is routinely used by the Bárány Society process. And so we created this criteria whereby each of these criteria, A through D, have to be fulfilled. And so criterion A is that this is characterized by or defined as a chronic vestibular syndrome, so at least 3 months of duration, with at least 2 of the following symptoms: postural imbalance or unsteadiness, gait disturbance, chronic dizziness, and or recurrent falls. Criterion B, this is a mild bilateral peripheral vestibular dysfunction, akin to the idea behind presbycusis or presbyopia, documented by at least 1 of the following: a VOR gain measured by video head impulse testing between 0.6, which is the threshold for bilateral vestibulopathy, which is a different diagnostic category, and 0.83, which is a synthesis of a number of studies that have looked at normative levels of VOR gain with the video head impulse test that have been done across a number of studies internationally. Another way to document this is a VOR gain between 0.1 and 0.3 upon sinusoidal stimulation on a rotary chair with these specific parameters, or reduced caloric responses with a sum of bithermal maximal peak slow phase velocity on each side between 6 and 25 degrees per second. Criterion C is that individuals have an age of greater than 60 years, greater than or equal to, and these symptoms are not better accounted for by another disease or disorder. So we provided extensive notes, important points to recognize when thinking about these diagnostic criteria. The first relates to what are the potential differential diagnoses for presbyvestibulopathy. And so here we developed a list of potential other diagnoses to consider and ways in which those other diagnoses may be distinguishable from presbyvestibulopathy. So benign positional vertigo, we would expect to see a positive positional maneuver, provocative maneuver. Unilateral vestibulopathy, this condition is expected to be bilateral. Bilateral vestibulopathy is a more severe form of presbyvestibulopathy, and it meets very specific criteria as well as outlined in that diagnostic criterion. And then other causes of dizziness, such as functional dizziness, we wouldn't expect to see these physiologic deficits. If we didn't see these, then we may think more about a diagnosis of a functional condition. Other sensory motor reasons for dizziness and some of these symptoms, we wouldn't expect to see these bilateral mild vestibular deficits. Central nervous system conditions that could also manifest as dizziness and imbalance, and some of the cardinal symptoms, we wouldn't expect to see vestibular deficits, or there would be other features of those diagnoses, such as downbeat nystagmus, extrapyramidal symptoms, other symptoms of normal pressure hydrocephalus. And with these other categories, such as the use of vestibular suppressant medications or intoxication, again, we wouldn't expect to see these mild bilateral peripheral deficits. So some other important notes to consider in terms of these diagnostic criteria to sort of add some nuance to them is that these age-related conditions often involve simultaneous impairment of multiple organ systems. So even in that previous slide, looking at the various elements of the differential diagnoses, multiple of those diagnoses can be existing at the same time, but simply don't fully explain the entire symptom complex that these patients are experiencing. So there may be simultaneous impairment of multiple organ systems, as well as a reduced ability to compensate for physiologic deficits, both of which tend to occur in older adults with the aging process. It tends to be a global process or a broad-based processes that may reduce function in a number of different organ systems, in addition to the ability to compensate for those deficits. So PVP likely occurs simultaneously with other sensory and functional losses, as noted here, which collectively result in this phenotype of age-related symptoms of postural imbalance, gait disturbance, or recurrent falls. We cannot definitively know the extent to which PVP is contributing to these symptoms. So this classification is simply considering the presence of these symptoms along with documented vestibular physiologic loss in older adults. So the extent to which those physiologic losses contribute to the overall phenotype, that cannot be determined. It's simply the coexistence of those two factors. Another note to make is that we define mild vestibular loss as in between normal vestibular function, as we described based on results from a number of studies, and also the threshold for bilateral vestibulopathy. We chose 60 years as the cutoff for PVP based on the United Nations cutoff for older adults. And we note that histologic studies have documented degradation in vestibular end organ structures at age 60. And there has been observed additionally a marked decline in vestibular hair cell populations in both canal and otolith sensory epithelia beginning at age 50. Similarly, degeneration of saccular and utricular otoconia has been described beginning at age 50. Additionally, significant reductions in vestibular nerve fibers, as well as vestibular nuclei and ganglion cell counts have been described as early as age 40 and certainly by age 60. So the United Nations cutoff for older adults is certainly consistent with what's been observed histopathologically, both of which support our designation of age 60 as the age threshold for this criterion. Another important note has been mentioned is that some individuals may have multiple diagnoses. This diagnosis does not preclude other diagnoses. For example, BPPV, patients may have presbyvestibulopathy and BPPV, or a neurologic disease such as Parkinson's disease in addition to PVP. The critical point here is that the other diagnosis may present with additional symptoms, for example, brief positional episodes of vertigo or bradykinesia and rigidity, but the other diagnosis doesn't fully account for the symptoms in the diagnostic criteria of PVP. So I just wanted to conclude with some thoughts of the panel in terms of what are some current knowledge gaps and future directions that we surfaced in the process of developing these criteria, and that hopefully we'll be able to address in a subsequent revision of these criteria, which we anticipate doing in the next 3 to 5 years. And so the first is we relied on self-reported symptoms, postural imbalance, recurrent falls, et cetera, to characterize this diagnostic criterion. In the future, we can envision perhaps using more objective tests to quantify the symptoms, such as posturography, the dynamic gait index, or even using more formal patient-reported outcome metrics, or PROs, such as the dizziness handicap inventory, and incorporating these more reproducible measures into the classification. There is discussion of inclusion of cognitive symptoms in the diagnostic criteria, given the increasing literature of the impact of vestibular impairment on these types of skills and symptoms. We didn't include otolith impairment or otolith dysfunction as part of these diagnostic criteria, physiologic criteria, despite evidence that has shown, for example, a reduction in CVAMP response amplitudes with age. And it was felt during the development of these initial criteria that there wasn't sufficient standardization and reliability of these measures, although as measures of otolith function continue to improve over time, we hope that we can include these measures as well in a subsequent version of these criteria. We categorized PVP as a mild vestibular loss using specific numerical thresholds between bilateral vestibulopathy and estimates of normal function, based on population-based estimates. It could be that there are critical thresholds that lead to clinical symptomatology. And so we want to consider exploring that further in subsequent versions of the diagnostic criteria to make it not just a numerical scale, but perhaps having a threshold below a certain number that is typically associated with clinical impact. And then we want to give further consideration possibly in the future to subtypes of presbyvestibulopathy, such as canal impairment, otolith impairment, high frequency, low frequency, for example, as is done in the auditory system, to more granularly consider this diagnostic classification. Thank you very much for the opportunity to present this new diagnostic classification, and I'm happy to take any questions or further discuss during our discussion session.
Well, thank you very much, Yuri. It was a very nice presentation that you gave us context and also clearly explained it how out of this context the definition arose. And we got a few questions. There was one question on rehabilitation, but I would like to maybe take before one on the diagnostic criteria, which is quite tricky, that question. It is from Professor Yin, and he says that faults in elderly patients may be related to a lot of reasons. How to make sure the faults are related to PVP in routine clinical practice? Or how do you make sure that it's not better accounted for by other disorders?
Yeah, I think that's a great question. And I think because falls are so multifactorial in older adults, it often is difficult to pinpoint. I think a lot of the literature actually suggests that it's the sort of concurrent occurrence of multiple deficits that actually leads to fall risk, because there are built-in redundancies in terms of balance control. And it's sort of the concurrent decline in multiple systems that leads older adults particularly to fall. And so I think, it is difficult to establish. And I think people are trying to understand, what is the specific vestibular contribution, the independent contribution. Of course, it will be synergistic with declines in proprioception, vision, et cetera. But I think the point that we wanted to make with this classification is that, if in the course of examining a patient who has a history of falls or who is at risk of falls or reports gait and balance problems, if they have evidence of vestibular deficits, those should certainly be addressed as part of a falls reduction program that, perhaps they're also using multiple medications, perhaps they also have, peripheral vision losses, but certainly as part of a comprehensive falls reduction program, vestibular deficits that are identified should be referred potentially to see if there is a benefit of an intervention like vestibular therapy. Just to make the point that currently that's not necessarily part of the assessment of a patient at risk of falls, and it certainly needs to be considered, and action could be taken to help in the context of an identified deficit.
Yes, there was one question addressing exactly that, is the importance of vestibular rehab in elderly patients who begin their decrease in vestibular function. Well, the diagnosis didn't really relate now to interventions, but maybe you can comment briefly on that comment.
Yes, absolutely. I think there are a number of studies that have looked into the benefits of vestibular rehabilitation in older adults, and older adults benefit just as much from vestibular rehabilitation as younger adults. That there might be some concerns about capacity for motor learning, et cetera, the plasticity, but there does seem to be demonstrable benefits in older adults similar to younger adults. So I think certainly age, isn't something that should be a reason not to consider vestibular rehabilitation. I think, as we think about aging of the vestibular system, perhaps unlike some of our younger patients who have exhibited an episodic loss of vestibular function that, may be temporary and or sort of fixed, and there's full function contralaterally. With the aging vestibular system, it is a dynamic, progressive loss of sensory function over time. And so I think we may have to also rethink how the vestibular rehabilitation is delivered and conceptualized. And instead of being an episodic 8 to 12 week delivery of vestibular rehabilitation, as is recommended in the clinical practice guideline, it may need to be more of an ongoing type of program or therapy, in the same way that we recommend people engage in aerobic or cardiovascular or, strength training, that it needs to be both to improve and to, prevent further functional decline from these ongoing declines that we know occur with the aging process.
Okay. Now there's a question by Sergio Carmona from Argentina. And I think he raises a question about the risk of overdiagnosing. So he asked, how can you make sure that general physicians can apply the criteria? The danger is to classify everybody over 60 with PVP and missing specific diagnoses like BPPV or Meniere's disease or even neurological conditions.
I think it's a great point, and we talked about that at great length, in designing these criteria. I think that's definitely a concern, that we don't want this to sort of be, kind of a in some ways, a diagnosis that precludes any other investigation. And so I think we try to emphasize, those ideas by making the point that, Presbyvestibulopathy could certainly coexist with other conditions. And it's really, something that should be diagnosed if there's no other condition that, also and or sufficiently, meets the clinical presentation. And so I think the broader point that we're trying to make is just that the potential benefit of vestibular treatment, and currently it's vestibular rehabilitation, potentially in the future it's other, prosthetic devices or, other types of stem cell therapies, et cetera. Right now I think the frame is mostly thinking about vestibular therapy, particularly for older adults. We don't want to miss an opportunity to deliver that to older adults who may benefit from that, because currently, as part of patients presenting to their primary care doctor who are at risk of falls, vestibular impairment is not typically top of mind. And there's, it's very infrequent that patients are being referred to vestibular therapy, specifically vestibular therapy, as a component of a fall risk reduction strategy. There's more emphasis on general gait and balance training, certainly thinking about medications. Vision, is one of the cardinal sensory systems that is considered, widely in the primary care literature and practice. But the vestibular system isn't typically considered. And so I think just even, having it be further on the radar screen, that certainly BPPV conditions like that, specific vestibular diagnoses are common, but also this underlying, sort of chronic age-related decline may be playing a role and may be actionable. You know, I think that's sort of the broader goal, you know, taking note of the risks associated with that, which is that, you know, that there could be less emphasis placed on those other diagnoses that were previously considered to a greater extent.
It's certainly clear that when new treatment options come up, like prostheses or maybe stem cell, defining the contribution of the vestibular organ to the clinical problem will be much more pressing than it might be today. Somebody asked risk factors for developing PVP.
So that's a great question. And when we've looked at it epidemiologically in the population, you know, it seems, you know, certainly looking at things like that postural metric, even histopathologically looking at temporal bone specimens, you know, the declines occur very early, including starting in middle age. And so, you know, what are the predisposing risk factors? You know, we've found that general, you know, just looking at a population level, general, you know, sort of risk factors for health and disease. So cardiovascular risk factors, diabetes are risk factors for, you know, evidence of postural impairment as seen by databases like the NHANES. You know, certainly we're all aware in our practices that exposure to ototoxic types of medications or other agents, you know, certainly contribute to it as well. There's increasing literature that noise is also a risk factor and that it influences, you know, otolith function, perhaps also canal function. And so that tends to be, you know, more prevalent in terms of the type of exposure. But I think we don't have a great handle on, you know, specific, you know, certainly the genetic risk factors for Presbyvestibulopathy. You know, we have certain ideas for other vestibular diagnoses, but, you know, kind of at a broader population level, what are some of the main risk factors that contribute to it, I think are not very well understood.
Okay, I think here's another question by Sergio Carmona on clinical diagnostic criteria of the definition. Why don't we use classical vestibulospinal signs like Homberg test or Bárány index or gait evaluation?
And, you know, I think that's a great point. And I think it probably relates to the point that you raised earlier, Dr. Carmona, about, you know, how do we try to isolate the vestibular contribution to the overall phenotype? And, you know, the panel felt that some of these other metrics like Romberg, you know, for example, or, you know, measures of gait are much more synthetic functional measures and don't specifically isolate vestibular function to the same extent that the vestibular physiologic measures do. And so it would potentially confound the picture, or, you know, we wouldn't necessarily surface a specific vestibular deficit, you know, in the context of using some of those metrics. And so I think they may be important as outcome measures or symptomatic measures when we talked about, you know, thinking about, you know, instead of self-reported gait or balance problems, we may want to consider having impairment in the Romberg or, you know, certain types of performance on the dynamic gait index as part of the criteria, but more in terms of what are the types of functional limitations as opposed to the vestibular deficits. I think as we start to understand more about particular signatures on the Romberg, you know, if we implement posturography and accelerometry and can have sort of a vestibular signature or profile on, you know, Romberg performance, and we can better isolate a person with vestibular loss and how that might manifest on something like the Romberg more specifically, I think those measures could certainly be used in terms of the vestibular diagnostic criteria too, you know, in that item B of the criteria.
Yeah, the question is, well, it's not diagnostic, it is about if general physical activity can be used to prevent the evolution of presbyvestibulopathy, or maybe to slow it down. Do you know about anything like that?
Yeah, I think that's a great question. And, you know, I think there's not really great evidence that's looked into that. I think it would certainly, you know, be very interesting to know that do people who engage in general, you know, cardiovascular, aerobic, strength training activities, you know, does that in and of itself, those, you know, sort of more traditional health promoting activities, does that forestall, you know, vestibular declines, you know, or do individuals need to engage more in balance activities that are more specifically targeting the vestibular system, so involving head movements, specifically the type of activities that are encompassed in vestibular rehabilitation. just focusing more on that, is that required to actually, reduce the types of deficits in vestibular function that occur down the road, or at least the ability to compensate for it. So I think these are all, open questions that I think some of the observing the prevalence and the impact and categorizing this diagnostic entity, helps hopefully open the door for studies that explore that.
Okay, I know that you have to leave in a few minutes because you go for another meeting. Maybe two last questions to take is, one is about the threshold of 60 years. Why is that? And the other one is the use of noise to saccular and providing the study proving that noise causes saccular and utricular loss.
Yeah, so I think 60 years old, that was also the subject of a lot of discussion in our panel. And, in the United States, the AARP, for example, which is a big group organization of older adults in the United States, their membership starts at age 50. And, certainly some of the histologic losses that we've observed start in middle age, 40s and 50s. Other definitions are 65, studies that focus specifically on older adults in the literature often start at age 70. And so, we just sort of chose 60 as, a number, and we could anchor it on what the United Nations considers, a definition of an older person. So I think certainly as the population, becomes healthier, as secular changes occur, at the cohort level, that number could certainly be subject to change. But we thought that it sort of was a good balance between, when the histologic changes are shown to occur and when, a lot of the functional deficits start to be manifest as well. So, but I think it's certainly part of what will be continually revised in these diagnostic criteria, because certainly some individuals can experience these losses earlier, consistent with what we see in temporal bone studies. There are a few studies that have shown a relationship between noise and saccular and utricular loss. There's a group at Michigan, Mike King is one of the principal investigators of that work in his group, and they've shown that, both in humans and in animal experiments, that, saccular stimulation and suprathreshold stimulation, that noise stimulation does result in loss of sensory epithelial integrity of the saccule, and also firing responses from the saccule. And so there is evidence to support that. And certainly in our studies, we found that individuals who have reduced CVEMP responses do have a history of, are more likely to have a history of noise exposure. And so we published some of that work also in otology and neurotology. Geraldine Zuniga published some of that work. And so I think it is another interesting area to explore, the perhaps vestigial sensitivity of the otolith organs to sound stimulation, and how that impacts, functional balance outcomes later in life.
Okay, well, thank you so much, Yuri, again, for your nice presentation and the lively discussion. And so you need to move on to the next meeting, as far as I understood.
Yes. So American Neurotology Society. Thank you so much for this opportunity, Alex.
Thank you again.
Great.
Okay, so
thanks.
then I move on to our last presentation for this Pre-Bárány meeting, which will be given by Yoon-Hee. She gave already a nice presentation yesterday. So Yoon-Hee is Associate Professor of Neurology at the University of Minnesota in the United States. She's a neurotologist who studies motion perception with neuroimaging and neuromodulation, and she looks after patients with neurological disorders and headaches. And today's presentation will be about motion sickness. Motion sickness, which is that a disease? Well, we'll learn about that in a moment, and then you can ask your questions to her after that. So we can launch her presentation.
Hi, I am Dr. Yoon-Hee Cha. I'm a neurotologist from the University of Minnesota in the United States, and I will be presenting on the diagnostic criteria for motion sickness. So thank you for the opportunity to share the work that the Motion Sickness Classification Committee has done over the last several years to create consensus criteria for this disorder. As the chairperson of that committee, I have the honor of presenting on behalf of the subcommittee. The committee had 9 members, including myself, as well as 2 advisors. The members of the committee were leaders in motion sickness research who came from 3 different continents, bringing backgrounds in neurology, otorhinolaryngology, physiology, psychology, and psychiatry. The committee met over several years, starting with the initial decision to create a motion sickness subcommittee separate from the maldebarkment subcommittee in March of 2017. Subcommittee members were invited over the next year, and through communications by email and meetings, draft criteria were proposed by November 2019 and reviewed by the classification committee. The full paper with the criteria were presented to the entire Bárány membership on January 2020, revised to address comments, and then published in preprint form on February 2021. Further edits were made with the final edition in press at this time. Motion sickness is a phenomenon that most people can relate to. It is in fact a normal physiologic response to motion of an intact vestibular system. Whether motion induces sickness is dependent on the interaction between a specific stimulus and individual susceptibility. It can become problematic, however, when the symptoms are severe. So, though it is common, it can be helpful to define when it is a disorder. The most common symptom of motion sickness is nausea, and the word itself has the same root as the word nautical, which means ship. Descriptions of motion sickness go back to before 400 BCE and were eventually noted in other forms of transportation, such as caravans and cars and airplanes. Interest in motion sickness research took off when the need to transport large groups of people for military purposes became important. And then, of course, when space exploration in the 1960s became an international priority. In the modern age, we are beset with both real and apparent motion that can cause motion sickness. More specifically, motion sickness can be caused by either physical motion as well as apparent motion, or motion that is implied by visual stimulation. For simplicity's sake, the committee called physical motion sickness to be motion sickness, and motion sickness induced by visual stimulation to be called visually induced motion sickness. Motion sickness can be induced by any kind of vehicle like cars, trains, airplanes, ships, as well as passive motion from amusement park rides and even the tops of very tall buildings that sway. With modernization, the role of visual stimulation causing motion sickness has become more of a concern. Interest in visually induced motion sickness started to increase when ship and flight simulators used for military training exercises were noted to induce symptoms very similar to physically induced motion sickness. Now, most people are not in the military, but can be exposed to rather intense visual motion that can induce sickness from movie theaters, particularly those with very large screens with surround view, virtual reality, and immersive video games, computers with larger screens, and even in some cases, mobile devices in people who are particularly sensitive. There are several theories that have been considered over the years for why motion sickness occurs. These are all mentioned within the paper. The theories range from the sensory conflict and neural mismatch theory that proposes either internal conflict between different sensory modalities or even between inner ear organs, or conflict between what is perceived and what is expected. There are other theories that motion sickness symptoms are similar to those experienced when ingesting toxins, and there may be a relationship between pathways that are stimulated from both motion and toxins. And of course, maybe we're just unlucky, and there's no protective reason why we develop motion sickness. Vestibular pathways may just be, unfortunately, overlapping with autonomic and immunogenic pathways, and there's really no functional benefit to developing motion sickness. The symptom categories that were selected for the criteria were based on the most commonly referenced motion sickness severity and susceptibility scales. To date, the most commonly used scales with the most validation are the Pensacola Diagnostic Index and variations of it, the Motion Sickness Questionnaire, and a sub-questionnaire within it that queries visually induced motion sickness called the Simulator Sickness Questionnaire, and finally the Motion Sickness Assessment Questionnaire. These are all outlined in Table 1 of the paper. It was important for the committee to use previously validated questionnaires as the basis for the criteria rather than creating criteria from scratch. So after much discussion and revision, the committee decided to divide motion sickness and visually induced motion sickness into 2 different disorders but to use a common set of criteria because the symptoms induced by each were similar, though differently weighted. So motion sickness is diagnosed when the sickness-inducing stimulus is physical motion of the person. Visually induced motion sickness is diagnosed when the stimulus is visual motion. So an acute episode of either motion sickness or visually induced motion sickness is an episode that meets criteria A through D, which is either physical motion of the person or visual motion as appropriate, that elicits signs or symptoms in at least one of the following categories, experienced at greater than minimal severity. And these would be nausea and or gastrointestinal disturbance, thermoregulatory disruption, alterations in arousal, dizziness and or vertigo, headache and or ocular strain. These signs or symptoms appear during motion and build as exposure is prolonged. These signs or symptoms eventually stop after the motion stops. And these signs or symptoms are not accounted for by another disease or disorder. So a few words of clarification of the symptoms. The 5 most commonly induced categories of motion sickness include nausea and or gastrointestinal disturbance, which is a feeling of sickness and or an urge to vomit, which can lead to actual vomiting. It is usually preceded by stomach awareness or discomfort and changes in salivation or appetite, burping, or a desire to move bowels. Thermoregulatory disruption can take the form of sweating, typically a cold sweat, meaning that the sweating is not because the room is hot. In fact, the individual can feel cold and still sweat. Now, they can start with a feeling of warmth or flushness before moving on to feeling cold and sweating, and they often turn pale. Alterations in arousal, which has been referred to as the Sopite syndrome, can include drowsiness, fatigue, tiredness, and difficulty with concentration. Dizziness and vertigo can be symptoms of motion sickness, as they were used in prior motion sickness scales, referring to feelings of disorientation and faintness, and in some sense, in some situations, visual motion illusions, though very severe rotational vertigo is typically not a symptom of motion sickness. A headache or ocular strain can take the form of head pain or fullness, eye strain, difficulty focusing, or blurred vision. And these are the predominant symptoms in visually induced motion sickness. Although not an exhaustive list, we've listed some of the most common triggers for motion sickness, including water, air, and land transportation, as well as other triggers like amusement park rides, the tops of swaying buildings, vestibular stimulation in laboratories. And for the very few people out there who go into space, perhaps more in the future, space travel, it's important to note that you can be susceptible to motion sickness to one kind of stimulus, but not another. So you can be seasick, but not car sick, or seasick in small boats, but not in large boats. So people who tend to be highly susceptible to motion do tend to be susceptible to multiple kinds of motion, but we cannot make a direct correlation between one kind of stimulus susceptibility to another for an entire group of people. So for example, we can't say that people who tend to be car sick also tend to be air sick. The interaction between each stimulus with each person has to be assessed individually. The question is, when do these symptoms constitute a disorder? This is what the committee had to tackle because we all know that motion sickness is quite common. So designated motion sickness as a disorder under appropriate circumstances is a step towards recognizing this syndrome as a true cause of morbidity. Now, people do adjust their activities to avoid motion sickness inducing situations, but sometimes that cannot be helped, such as children riding school buses or an adult taking the subway to work. Now, some people might avoid going on boats or flying in airplanes, which can be disruptive to vacations and social activities with family and friends. If motion sickness is recognized as a contributor to morbidity, we could quantify that morbidity, obtain resources for patients, and maybe work on accommodations. Another step is to be able to do proper coding. There's a saying, if you can't measure it, you can't improve it. This was said by a famous business management consultant, Peter Drucker. As we know, there are many potential triggers for motion sickness. However, there is only one ICD-10 criteria or code for motion sickness. Now, in contrast, the ornithologists were able to get dozens of codes for bird-related encounters, including at least 9 that have to do with just interactions with parrot species. So we're a little bit behind the bird trauma people. So here are the definitions of motion sickness disorder and visually induced motion sickness disorder. These are defined by at least 5 episodes of motion sickness triggered by the same or similar kind of motion stimuli. These symptoms are reliably triggered by these stimuli, and the person does not habituate to the trigger over time. The motion trigger leads to some kind of behavioral or emotional response, including activity modification to get away from the stimulus or to make it end. So for example, they try to get off the bus, that's making them sick. Avoiding the motion stimulus, such as avoiding boat rides if they make them sick. Having anticipatory aversion prior to the motion exposure if the motion cannot be avoided. Now, the challenge is that people are smart and will generally modify their behavior to prevent getting sick, so they can also be diagnosed with probable motion sickness disorder if they have had only 2 to 4 similar episodes. One question that came up was, since motion sickness is so common, isn't the true measure of it being a disorder that it causes disability? So there were lengthy discussions about this, but we ultimately agreed that disability is difficult to quantify and is very much dependent on circumstances. So if you were someone who got really sick on buses, but you really didn't have to ride the bus for anything, and you could largely avoid being motion sick, are you medically different than someone who has the same susceptibility, but who was forced to ride the bus anyway? No, you both have motion sickness disorder, but only one of you is suffering disability from motion sickness. Now, the other aspect of the discussion is that since there are already validated disability scales that exist, it would be better to pair the motion sickness criteria with existing scales as appropriate, such as with the Sheehan Disability Scale or the Social Life and Work Impact of Dizziness Scale. So one common disability scale in use is the Sheehan Disability Scale, which is a rating scale from 0 to 10 of the impact that any symptom has on work or school, social life, and family life. There are 2 quantitative responses on days either lost or made underproductive from these symptoms. The Sheehan Disability Scale is not disorder specific. A similar scale is called the Social Life and Work Impact of Dizziness that can be modified for use with motion sickness. These are answered in a yes/no manner and can be asked pertaining to whether motion sickness has created difficulties in work, social life, family life, or the ability to travel. So why did the subcommittee not choose severity for the criteria? So severity, like disability, can be subjective and circumstance dependent. So the criteria cannot account for all combinations of reactions and circumstances. There are also already several severity scales, and once again, we did not want to completely reinvent the wheel. The paper provided background on the most prominent motion sickness severity scales. Again, table 1 shows the most common motion sickness severity scales that use multiple symptoms. So on these multi-symptom severity scales, the domains include gastrointestinal, oculomotor, and cognitive symptoms. And details of what entails these scales can be read in the paper. Table 2 listed the most common single item questionnaires, which use a single numeric reporting of symptom severity that encompasses all symptoms. Similarly, susceptibility is circumstance dependent and can vary with time. People do self-restrict behavior and avoid situations that provoke motion sickness, which can make susceptibility difficult to assess. And susceptibility is difficult to generalize, except in extremely susceptible people who tend to be motion sick to many triggers. As background, susceptibility to motion sickness does vary with age. Infants are fairly resistant to motion sickness until about age 2. The peak age of motion sickness susceptibility is between about ages 7 to 12, and then starts to decline through adulthood in most people. In a small proportion of people, susceptibility to physical motion-induced sickness can increase. In contrast, visual-induced motion sickness tends to increase with age. There's quite a bit of debate on whether motion sickness is worse in women than in men. About half of motion sickness studies show that there is no difference, and half show that women tend to be more motion sick than men. While the bias towards more motion sickness is generally shown toward women, these studies tend to be older studies and those that were questionnaire-based rather than experimental-based. While the converse has not been shown that men are more susceptible than women, for perspective, the age effect is about 3 times greater than the sex effect. It is also important to note that whether looking at age or sex, there are many more individual factors that determine susceptibility than either alone. The two main susceptibility scales in the literature are the Pensacola Motion History Questionnaire and the Motion Sickness Susceptibility Questionnaire short form. So the MSSQ short form presents 9 situations that can cause motion sickness, and the individual indicates whether they never, rarely, sometimes, or always feel motion sick in these situations. The MSSQ queries motion sickness susceptibility as recalled by the patient from before the age of 12 and the last 10 years of adulthood. The correlation between childhood and adult motion sickness based on this scale is about 0.65, which is reasonably strong. The total possible points for childhood and adult motion sickness together is 54 points. So based on 54 possible points, 50% of individuals will score 11 points or below, 75% 19 points or below, and 90% at 27 points or below. This is half of the maximum points that can be scored. And only about 5% will score above 31 points. So the paper briefly covered the relationship between motion sickness and other vestibular disorders. It is fairly well known now that migraine and vestibular migraine will increase motion sickness susceptibility. Meniere's disease in general will also increase motion susceptibility. Vestibular migraine can increase or decrease susceptibility depending on whether the vestibulopathy is compensated or not and how acute the symptoms are. Bilateral vestibulopathy will decrease motion sickness susceptibility, and BPPV does not seem to predict either an increase or decrease in susceptibility. Now, motion sickness can be diagnosed without laboratory testing, but this should be considered if susceptibility increases quite suddenly or if motion sickness starts immediately with head movement. This should raise concerns for an underlying vestibular asymmetry, ocular motility problems, and visually induced motion sickness, the emergence of migraine, or other central nervous system problems, which should prompt a more thorough neurological exam. The paper briefly covered therapeutics, not because it was meant to be a review article on therapeutics, but to bring to light the fact that people engage in a lot of behaviors that can mitigate motion sickness, and this will affect susceptibility. So primarily, people do modify their behavior during motion sickness inducing circumstances, such as limiting head movements, or looking out to the horizon, inducing habituation by practicing with small amounts of movement, taking medications, or using other practices like listening to music or using pleasant smells, engaging in breathing exercises, or meditating. The effectiveness can vary quite widely, however, and if habituation is tried, it can be quite stimulus specific and not generalized across all situations. Now, motion sickness is a real challenge for humans who are terrestrial beings, but now that we are moving faster on land by artificial means and also navigating in the air and water, this can become a bigger problem with time. So what other modes of transportation will we create that will test our ability to adapt to those situations? Now, there have been non-invasive neuromodulation methods explored to increase motion intolerance. And greater knowledge in what causes motion sickness can also help create environments that reduce sickness. So motion sickness criteria may need to be modified to changing environments and the ability for humans to adapt to new stimuli. So these criteria are the first to be presented to encourage recognition of motion sickness as an important syndrome and cause of morbidity amongst our neurotology patients, and to help establish some standardization in diagnosis. So on behalf of the Subcommittee for Motion Sickness Criteria for the Bárány Society, I thank you for your attention. And at this time, I'd be happy to take any questions.
Thank you, Yoon-Hee, for your nice presentation on this topic, which I think took really a long time to mature, because we had to really struggle with a lot of issues on the symptoms, on the severity, not mixing diagnostic criteria and disability criteria. Eventually, I think we managed to tease it all apart quite nicely. From the panel, there are no questions again at this moment. Just to make sure, if we go back to the criteria, so just developing gradually headache during exposure could qualify as a motion sickness, couldn't it? Because we were discussing at some stage if you need more than one symptom, but eventually the decision was that one of those can be enough to make it diagnostic.
Yes, that is correct. So we had discussions about how many symptoms were required to have this diagnosis, and certainly the more symptoms that you develop during the motion trigger, the more specific the episode is, to motion sickness. And so the question was, if you're going to put headache, is it any different than, say, nausea, right? Is it any different than getting a cold sweat? There was no way for us to say that any symptom was, should have any greater weight than any other. I mean, there's some, a few studies that show that there's, sometimes a certain order in which, motion sickness symptoms can evolve with the sickness, with the event. But at the time that we were, writing the criteria, I don't think that we could have created a hierarchy. So they were all kind of weighted all the same.
Yeah, I think that is an important point, and it was a long discussion about it. Let me see, just a question came in. Can you comment on using the motion sickness questionnaire to identify military recruits for preventative habituation training before assignment to an occupation in the back of an aircraft with no visibility of the horizon?
Ooh, I'm not sure that I have the enough background in the working with military recruits to advise on this. So using the MSSQ to identify military recruits for preventive habituation training.
So basically, do you know any criteria how to pre-select people who might be very susceptible from not susceptible for motion sickness for certain activities? Yeah.
I don't know. These criteria, they've evolved really mostly from the military. Even the MSSQ. I mean, there's I was hoping that one of the folks who've been doing motion sickness research for going back to the 70s would create a kind of genealogy of where these scales come from, because the most common ones are some they're part of the genealogy of the Pensacola scale, right? And this is from originally like from the Air Force. And so these, most of these studies are done either in the Air Force or in the Navy. So I'd be happy to look into that and asking people who specifically still work with people in the military now. And we've got people on the committee who do. So send me an email and I'll look into it a little bit more. I mean, you might need something that's a little bit more specific, because the MSSQ is looking at, a lot more kind of civilian life activities, right? Like cars and trains, and going on amusement park rides. So whether it, predicts whether you get motion sick on, certain boats of a certain size or military aircraft of a certain size, I don't know whether it has any predictive value.
Yeah, I think it's, as far as I know, it's very difficult to give a good prediction. So we got a question coming in from David Newman-Toker. So he questions again the topic about headache as a motion sickness a symptom. So if you have a headache induced by visual motion, you have visually induced motion sickness and not vestibular migraine.
Yeah, I think no one knows these criteria. The process of creating criteria, I think, better than David Newman-Toker. So, I mean, from the standpoint of, you know, say, would this, what is the sort of cutoff, right, between visually induced motion sickness and vestibular migraine? I mean, for vestibular migraine, of course, you'd have to have a personal history of episodic migraines, you know, and with the vestibular symptoms lasting, 4 to 72 hours, etc. Yeah, I think it's tough. I mean, the thing that we also added into the criteria, you know, is that that whatever symptom is triggered by the trigger, whether it's visual motion or, you know, real physical motion, that, you know, it does start to abate, you know, once the symptom, or once the trigger is over. You know, and the more symptoms that are triggered, you know, the more specific they are, you know, to that entity, you know. So yeah, I wish I can say that there is there's like a certain quantified amount of, you know, symptom that you have to get to be more likely to be visually induced motion sickness, you know, versus vestibular migraine. But I think you also look at the entire context of, you know, what the person's other history is, and sort of how time locked, you know, to the stimulus their symptoms are.
Yeah, I think the latter point is probably the important one. So if after the exposure the headache wanes away fast within half an hour, then we are probably in a motion sickness scenario. And in the headache, there is no specification of what headache it is, because there is no comment on the phenotype of the headache as such.
Right. And I don't think that there wasn't really enough information in the literature to say whether it was a migraine type headache or whether it was more of a tension type headache. And so we just left it unspecified.
Mm. If you could go back to, because it was a long process, and the process of building this definition had the particularity that many of the people involved are actually not doctors, but they are scientists from military context, and but I think their input was crucial because they have so much experience in the military on this topic. But could you give us maybe another time a little bit of a feel what the controversies and the main discussions were about to get this definition done?
Yep. So this was a really good experience for me, because when we first started to think about making, you know, criteria for Malador-Bárcman syndrome, we had put motion sickness kind of together, and then it became separate. And so I've done a lot of research in Malador-Bárcman syndrome, but not in motion sickness per se. And so the group was amazing. I mean, these are, you know, top motion sickness researchers around the world. So it was a great experience. But of course, you know, there was a lot of you know, strong opinions sometimes. And so just to give you a sense of how many iterations, you know, we've gone through, we had at least 20 versions of the paper that had A, B, C, and D. So, you know, and you know, around halfway through, we scrapped everything and almost had to start from scratch. So, because, you know, and this is why we also kind of brought up the issues of disability, severity, and susceptibility. And I think that was a lot of what we had to talk about, right? Is you know, should we not actually create our own scale to make it a unified, because there were so many of these scales out, you know, out in the being, you know, used in different contexts. And so you know, the issue was, you know, should we try to create kind of a new entity out of what is already out there? At the end of the day, we said, well, no, we can't really do that because we've never tested this, right? You know, if we create a new scale, we're not going to, you know, we have no validation, you know, for those scales. And so, you know, we had proposed a severity scale and a susceptibility scale. And so, you know, we got so far with that, and then we decided to not go further. So instead, what we did was we said, hey, let's just give all the data to people out there, and they can kind of pick what scale makes the most sense for their particular use. So for example, like if you're in the military, or if you are like a primary care physician just dealing with, you know, people who are just motion sick in cars, you might find different scales to be more or less useful. The other thing that we just, you know, just a few lines in the paper is to say, you can just ask people, you know, are you never, sometimes, you know, or often, you know, always sick in certain circumstances? And so you can just use a very simple Likert scale like that for, you know, just kind of a quick assessment.
Yeah, and the concept of the motion sickness disorder came up in the process, because that was not there to start with, wasn't it?
So when we had the motion sickness and the mild debarkment together, I thought, well, you know, but mild debarkment isn't motion sickness, right? And so so it kind of became a separate process. And it's one of these things, you know, that we all deal with these patients, and we know that they suffer a lot. I mean, this is a symptom, even though we say it's common, you know, it's very severe, very debilitating, you know, in some people. So I think recognizing it as a real problem. I think, you know, as I mentioned, you know, for some reason we have all these bird codes in the ICD-10, but you know, we have you know, just motion sickness as one thing, you know, out there. So I think bringing recognition to both motion sickness and mild debarkment syndrome, because there are a lot of times when those two disorders are actually conflated, right? Where mild debarkment syndrome is kind of presented as a form of motion sickness. Well, you know, it's not. It's almost like the mirror image of it. So I think being able to provide both sets of criteria in sort of a similar timeline, I think is really, really helpful to say, you know, here is how these two disorders are actually different.
Okay, well, thank you so much again for the presentation and lively discussion. That finishes the scientific part of this meeting, but the meeting is not fully finished, because Professor Lopez Escamez, who is one of the co-organizers of the Bárány meeting of next year, wants to give us a few informations about that meeting coming up. So Antonio, it's your turn now, please.
Thank you. Can you hear me now? Yeah. Okay. So first of all, I would like to thank Alex for your wonderful work during these 2 days, trying to make this fantastic meeting so exciting. We have a lot of participants in the chat, and this is just the beginning of the type of things that we would like to prepare for the next year. I would like to also thank all the participants, all the speakers on these 2 days that they have been presenting, despite they have other commitments in the United States. So I would like to share with you my screen, if I can. Okay. I hope you can see my screen now. I am aware that we are not in an easy task, because the year and the time that since we have the last meeting at the Bárány Society was a long time ago, and next year will be 4 years without any meeting. I think we have to try to do our best to get together in Madrid, and this is the type of things that we are planning. Probably we are going to combine scientific on-site meeting with an online meeting. And this is the proposal that we are now working. As you probably know, we tried to organize the satellite symposium in Granada last year. And our idea is that we are going to offer you a different schedule, different timeline according to the necessities of the Bárány, because people from different part of the world are going to attend to the meeting. So we will have early morning session that we have called the ASEAN sessions, and probably that will facilitate the combination of people in Madrid and people in Asia that could attend at the same time. We will have then a set of different sessions starting in the morning in Central European time, combining an online and on-site meetings, and we are planning to do this in both in the Satellite Symposium and in Madrid Symposium. And finally, we will have evening meetings in Central European time, and that will be a morning meeting for the American Easter time, and this is what we have called the American session. We are planning to have the scientific meeting in May, as you know. So the Satellite Symposium will be on the 7th and 8th of May, Saturday and Sunday. And the main meeting will be on Monday to Wednesday in the time schedule that we have organized. How can we make this possible because of the differences in time zones? For that, we are considering that the best way would be to have a registration a la carte. That means that every participant can select the part of the meeting that could be more interesting according to the topics and according to the time zone. So you will have a possibility to register just for the Satellite Symposium, and for the main meeting, you can register only for the Asian morning session. You can, of course, register for the on-site meeting that will be held in Madrid, and you can register for the American evening session, because it's a little bit difficult that people living in Asia can attend to the American session, and the same for the American. They cannot, probably because of the difference. Of course, you can register a full registration, and you can try to attend to all the sessions, and that will be possible on-site in Madrid and online. And we are considering that the meeting should have an abstract deadline that will be around 15th of December, because we need to organize all the abstracts. So the abstracts that were submitted, we have requested to all the register if they were planning to submit new abstract or not. We have some response, but I think that everybody that submitted an abstract should submit a new abstract confirming that they want to attend to the meeting, and that will probably give us real information of the expected number of attendance that we have with this changing and difficult to predict situation for the next year. So we have organized this kind of flexible program. So you have to consider if you are going to come here. Spain now is very safe country, but this situation is not the same everywhere in the world. This situation, unfortunately, may change in the future, may change to increase in the mobility, or may change to higher restriction. And for that reason, we are very open to this flexible program that I've shown before, that will combine online sessions with on-site sessions to facilitate the interaction. Of course, I think it's also necessary that we go have a general assembly for the Bárány Society, and this is mandatory that we will have an online voting system for all the members, because we have to take decisions for the future meetings. Thank you all for your interest in this Pre-Bárány Society meeting. Thank you, Alex, for your help.
Well, thank you as well. There is a question here in the panelist asking about what happens to people who have already registered since 2019 with this flexible registration system.
Okay, the plan is to return the fees that people that have paid in advance, and we will adjust for the difference in the registration fee according to that.
Okay.
This is what we have considering.
That's very good. Well, I think you had, and did you, regarding the abstracts, there's a question now because we didn't discuss that before. Did you consider electronic abstracts so we could also have an abstract session for people who do not personally attend, a poster session? Is that?
Of course. This is exactly what we have in mind.
Mm-hmm.
So we will have podium presentation and poster presentation online.
Mm-hmm.
We are making numbers. Probably we will be able to accept around 180 presentations. So what we will do will be to have podium sessions about 10 minutes and poster presentations about 5 minutes. That will be, poster will be selected between the submitted abstract, but we can probably, depending on the number of abstract that we finally receive, organize parallel session online. This is one of the things that we have, because we probably are going to have one single room. I know that this is something that for the majority of the audience in the Bárány are interested in, that the number of parallel sessions are reduced. But for the abstract presentation, particularly for the poster, I think that we are going to organize parallel session online that can make the things more flexible and possible to have more participants.
And there is a question if, I think it's probably meaning that presentations, if they will be available online later, if I understand that correctly.
Yeah, of course, for people that have registered and pay the registration fee, we are planning to have all the material online because this is the usual system in most online meetings.
Good. Well, I also hope that it will be a great success. It will be different than before, but I think many of us are longing to have again the opportunity to go for a nice drink and a nice chat, and not only to see each other through screens.
I think that everybody wants to organize the meeting in Madrid, and we really want that people may come. But we are very optimistic with the European, because I think within the European Union is going to be very easy. But I think that from the America and Asia, I don't know exactly if this is going to be possible. That will depend entirely on the COVID situation. And we have to be prepared for everything. And this is what we're trying to do.
Okay. You have the last word, Antonio?
Well, my last word is to thank you particularly for manage of this meeting and trying to make things so smooth and easy as usual. And to all the participants, I would like that all the people listening today give the message that we are going to hold the meeting in Madrid. We are waiting for everybody. We are prepared for that. But we have to cope with this COVID, and we will do our best. We wait for you next May in Madrid, 2022.
Okay, I will be there.
Thank you. Thank you, everybody.
Thank you, everybody. Bye-bye.
Bye.